be discussing whether it's useful to map the left bundle in the left ventricle when you are considering the left bundle branch area pacing from the right side. Conduction system pacing, especially in the country, has taken much of the electrophysiologists to embrace the technology because there are a lot of advantages from the economics point of view also. And it's in general becoming the standard of care in pacing. And when it comes to conduction system pacing, his left bundle area pacing, I think everybody is finding it more convenient. They're not even trying to look at what could be the outcome if they try for 10 more minutes at the his bundle. So much is the confidence among the implanters to go to the left bundle area straight away. Left bundle area pacing, especially in our country, is increasingly being considered in lieu of CRT, and some centers may make use of a left bundle lead in addition to the CS epicardial lead, what they call is optimization. Like in CRT, left bundle area pacing also has a non-responder group, not necessarily in the midterm or long-term outcomes, but from the point of view of narrowing of the QRS. Not all left bundle area pacing would result in the so-called acute narrow QRS at the end of the implant. So it is important that are there any predictors to figure out if you place at the left bundle area that would result in a narrow QRS, provided you have done that in a recommended fashion. It is generally believed that the proximal conduction block is amenable to correction by CSP, while distal conduction block, you can even call it as very distal or a myocardial conduction disease, may not be corrected by the traditional conduction system pacing, and there you may actually consider the LV epicardial lead, or you can consider hybrid approach. Surface ECG characteristics to predict the outcome in the form of the narrowing of the QRS, I believe they are suggestive at best. So delineating conduction pattern by some means might aid the decision making. Should we go ahead at the left bundle area to get the good QRS? This slide is kind of gives an idea about what are those means by which you can figure out the level of the conduction block along the conduction system pacing. The one which we commonly use is ECGs because it's easy and cheap and it's robustly studied. We can make out the block is at the suprahesian level, intrahesian level, whether there's a left bundle trunk is involved, whether some of the vesicles, etc. But not necessarily all the time it can differentiate between the different levels of the block, because mainly the left bundle branch block has multiple definitions. If you follow any one of those definitions, we still end up in saying that it may not be necessarily be sure that the level of the block is identified. The robust kind of information you can get is to actually get into the left side of the ventricle to study the conduction pattern. But then if you do this invasive EP study, you are increasing the time, you're increasing the cost, and there is an incremental risk. Now you can club that EP study with an electroanatomic mapping. It will give you much more robust idea about the level of the conduction. In fact, every single fascicle can be studied very neatly. You can actually quantify the conduction delay. But then it's again invasive, expensive, incremental risk. And then there are two more investigational studies, investigational tools, ultra high frequency ECG and surface body mapping, there's not much of an experience even world over. Whenever we see an ECG, and when there's a left bundle branch block, we usually go ahead and if the patient is in requirement for a pacemaker, we do not really look at whether it's a typical or proximal or a distal block. But there are certain ECGs where you can definitely say the conduction problem is in the conduction system. For example, this case where you have different degrees of widening of the QRS. If you look at the V1, there are certain narrow complexes, there are wider complexes. And so that left bundle branch block, if the patient is seen at this stage and one day when you have a left bundle branch block, nothing to be doubtful about this being the conduction system problem. And here, I think you can be almost certain that you'll be able to achieve a left bundle capture. For example, there's an occasion where you used to know that the patient used to have rate-related aberrancy, and now it has completely left bundle branch block. Well, you're almost certain that the problem is in the conduction system. This is the issue. Here, there's no proof in the earlier stages what this kind of was. And if you adopt any kind of formula, this could be considered as a conduction block. Mainly the problem in the conduction system and the myocardial. This is a prediction, but here, this particular example, you are almost certain that the problem is much more distal. So we have certain ECGs very, very clear that the block is in the conduction system exclusively, and there are certain ECGs where you can be certain that it is not the problem in the conduction system, and hence conduction system pacing doesn't help. And this one, for example, again, it's a debatable, the loss of R in most of the leads, and notching either in the proximal portion or the distal portion. So this led to some investigators to consider it is better to identify, because one of the very widely quoted paper on the patterns of the left bundle branch block, it comes from the Chicago University work, Gaurav Upadhyay and Roderick Tung. Many people quote this particular article when they discuss the conduction system. I'm actually surprised, but the literature says that the 65% time only the so-called left bundle branch block is proximal, either intrahesian or the left bundle trunk, or it could be in the varying degrees in both the fascicles. This 35% is, at least in my experience, seems to be too exaggerated, because even in some of those atypical forms of the left bundle branch block, we really had some good results. And in the context that the septal pacing, not necessarily demonstrating there was a true left bundle capture, when we were unable to do it, when there was a septal capture, the QRS was not really very wide as compared to what you get with the left bundle capture. So, but the literature says in the 35% of the times, the block could be distal, and then you may not achieve a good result. So for example here, if the block, for example 65% of the times, whenever you have defined left bundle branch block correctly, you have a block here, intrahesian, for example, is the basal, intrahesian, or maybe somewhere down the Purkinje. And then this is the one, it is easily amenable for the correction. So for example here, if the block is intact, the conduction is intact all along the Purkinje system, but this wide QRS is basically because of the myocardial disease, it doesn't work. The conduction system doesn't work. But this incidence may not be as much as 35% in our experience. So this one here, you can recruit. If the block is here, you can actually recruit by the conduction system pacing. So I will, for example, this is the one. You have a left bundle branch block, and most often you end up in this kind of a result. And for example, this one, however much you struggle, this is easily taken as a typical left bundle branch block, and however much you struggled, you wouldn't get the typical left bundle capture. And if you study further, you could notice here that the actual conduction system is completely intact. And this is the one I think the authors have quoted. Occasional cases where you can demonstrate this, you could do this. But I do not think we should be doing such kind of a greater detailed EP study on the left-hand side just to figure that your conduction system pacing may not work. We can actually do a significant and an extensive study of the conduction system. You can actually figure out where could be the delay, intrahesian, the left anterior fascicle, left posterior fascicle. You can do a detailed mapping to even on the right-hand side, and then you can even make the thickness of the intraventricular septum and all that. But I do not really consider it is necessary to map the left bundle from the left side to predict the outcomes before you start off. Economic costs and time that is associated may not be ignorable. And anyway, at this point in time, there are no published guidelines to support the routine EP study or even electroanatomic mapping to help understand the outcomes of conduction system pacing. Thank you.